Thank you so much. I know pediatrics is not always at the front of everyone's list of things to see at a conference, but I feel like this lecture hopefully will have some application for everybody who might hear it, and it's definitely one of the more, with increasing frequency, one of the more important things that we're seeing in the pediatric ICU. So hopefully there's some application for everybody here. So like Dr. Moore said, my name is Dr. Carter, pediatric intensivist at Phoenix Children's Hospital. It is my pleasure to be here. I'm excited to talk to you guys. I don't have any disclosures to make specifically. I did feel like it would be best in presenting this information to kind of go through a couple of cases that helped illustrate the wide variety of presentations that we're seeing, specifically with fentanyl ingestions in the pediatric population that are bringing them to the ICU. So we're going to go through a couple of cases, talk a little bit about fentanyl, how we treat or manage a fentanyl ingestion of varying degrees, and then talk about some of the more widely available information that we can distribute as physicians to families and communities to help combat this issue. So the first case is a 4-year-old male who came in with no past medical history, but was presenting with altered mental status. By report, mom says he was in his usual state of health until he was watching TV and then all of a sudden had trouble sitting up or eating lunch. Shortly after that, he collapsed and turned blue. Mom called 911 immediately. Per their direction, she reported that she did feel a heart rate, so she did not start CPR, but obviously EMS was concerned. The exam pertinent findings, so the patient was pale, non-reactive, normal appearance for age, but atraumatic, normal cephalic head, small but reactive pupils, shallow chest wall excursion, and minimal aeration and auscultation. No issues cardiovascular-wise. Neurologically, he had no spontaneous interaction with surroundings, but moves extremities and moans to deep noxious stimuli. This is your initial set of vital signs, a little bit soft on the blood pressure, but and then obviously the respiratory rate is extremely low for what would be deemed appropriate. EMS appropriately thought that this would be a potential for an opiate ingestion, and so they did give 2 milligrams of naloxone with minimal improvement in the patient's exam. So they brought him to the ED. They started him on a non-rebreather. His respiratory rate was up a touch from the field, but otherwise vital signs were pretty comparable to where they had been previously. In the emergency department, initially there was some reactivity with placement of IV and again with noxious stimuli. A few hours into his ED stay, though, mom actually came from the room crying that he had become unresponsive yet again and stopped breathing, similar to that initial presentation that she had noted at home. The initial lab work that was sent, you can see your blood gas there. Ventilation looks decent or a little bit acidotic. CMP and CBC were unremarkable. UDS was, the initial UDS screen was testing negative at that point in time, and then we had some cultures and things that were still pending. Mom met with the social worker and did confess that she had been abusing blues and believes that the child may or may have not have accessed her bag of pills that she had left on the floor, unfortunately. So with that history and the patient's presentation, an additional 2 doses of naloxone were given, after which there was improvement in his mental status and respiratory status. He was admitted to the hospital. Anytime we have a pediatric patient who has significant symptoms resulting from an opioid ingestion, especially with repeated doses of naloxone, they tend to get admitted to the hospital for further observation. In this specific situation, the child was given, or started, on a naloxone infusion. I did want to touch just briefly on the dosing in pediatrics for naloxone. There's lots of different routes that the medication can be given, and I bring this up because we're actually seeing naloxone available in many different situations. It's not just something that now you have to go to the ER for. There are actually many schools that have it in their office, sporting event centers that have it present. So EMS obviously is carrying it as well, and so the availability is widespread in large part because of the frequent ingestions that we're seeing in many different scenarios. But I think most striking is how we're seeing it so much at school, and that's why they feel the need to carry naloxone within schools. Oops, sorry. So it's important to note that pretty much any patient can receive naloxone. We don't have to have IV access, although the shortest onset of action is the IV dosage form, but it can be given IM, sub-Q, or intranasal, also endotracheal, and then it can be given as a continuous infusion. I won't read through the doses here just for sake of time, but you can see those. And then the continuous infusion, if multiple doses are required, obviously the duration of effect is shorter than most opiates, so repeat dosing is often necessary. The drip can be started at 2/3 of what the total dose was that was given to have a restoration of appropriate respiratory effort. So not a normal neurologic exam per se, but appropriate respiratory status. And so that's how you can change your dosing on a continuous infusion. And then you want to start weaning relatively quickly as time goes on. For this patient's hospitalization, again, we like observation for longer periods of time, especially in these little kids, just because they don't always follow the typical course. It's important to note that many hospital systems, their initial UDS does not cover fentanyl or certain types of synthetic fentanyls, and so it won't always come back as positive on that initial UDS screen. A comprehensive screen is often required, but it's important to know what your institution does actually test for in that initial UDS, because it often will come back negative. In pediatric ingestions, there is other things at stake as far as are there other kids in the home? Could other kids be at a safety risk? And so a child services referral is made as standard. Social work involvement is obviously key to ensure that the patient's being discharged to a safe environment. So that adds a different aspect to these ingestion cases. So that's the first one. I will say ingestion cases, especially in these younger ages, are becoming more and more frequently because of some pictures you'll see here of how these illicit medications or drugs are being made and marketed in a way. So it's important to recognize that we're seeing more and more, and not just fentanyl, but across the board, we're seeing a lot of those cases.
Question for you.
Mm-hmm.
Was DCFS consulted on this patient afterwards?
Yeah, so for our hospital, it's a standard. Anytime there's ingestion or even concern for ingestion or that potential, yes, so they are consulted. In this particular case, there was actually 2 other children in the home, and unfortunately they were removed from the mother's care because there was other paraphernalia and things found in the home. So it's standard, and prior to discharge, they will do a home check to make sure that things are appropriate. Yeah.
So is that just ingestion of like illicit drugs in that?
Yeah, so we'll still, not just with illicit drugs. In social work, or excuse me, oftentimes social work will meet with the family and deem would there be a DCSF consult because of safety issues. Let's say they have a prescription medication at home that isn't being cared for appropriately, left to where the children can still get to it. That would be deemed a safety issue, and a consult would still be made at that point. So yeah, this case we did, and there's a broad range, but most of the time if there's any concern at all, then we would consult them. The second case is probably one that more people are used to. This is an adolescent male who presented past medical history of ADHD and ODD, who presented via EMS after being found down at a party. Kind of sounds like a typical ingestion type picture of some type of an illicit substance. EMS described finding the patient unresponsive, cyanotic, hypoventilated, and with pinpoint pupils. He was given a total of 4 milligrams of intranasal naloxone with slight improvement of his respiratory effort. Upon arrival to the ED, the patient was vomiting and noticed to have copious respiratory secretions. You can see his vital signs there, obviously a depressed respiratory rate and desaturated to a sat of 86% on 15 liters via non-rebreather. So definitely showing some respiratory type symptoms that would be concerning on his initial presentation. So his mom arrived and was concerned because there's a strong family history of addiction and opioid use disorder. A friend from the party explains that over the past few months, the patient had been experimenting with oxy and other pills. Initially, he'd used 1 to 2 pills a week, and now he's up to 10 to 20 pills per day. He doesn't usually drink alcohol, but at the party he was drinking while smoking and may have used more than he normally does. That sounds like a significant amount, but we're seeing these pills become so readily available and the abuse just so much more rampant that we really are seeing patients, even adolescents, with this type of intake. It's a little bit shocking at times. These are the pills that are seen near the patient. These are meant to look like oxycodone pills. They're called M30s. It's a big thing that we're seeing coming over the border. And the issue is it looks like what you would expect an oxycodone pill to look like, but in fact it's fentanyl that is in the pill. So easier to make, cheaper to make, strong effect obviously. And so that's why drug cartels are making and distributing them. This patient's course, you can see, this is not his actual x-ray, but an x-ray that was very similar to his x-ray. The respiratory status continued to decline, significant hypoxia, and required emergent intubation. He got repeated naloxone dosing with improvement in his respiratory rate, but unfortunately his oxygenation was not improving. And as you can see from the x-ray, pretty significant development of an ARDS type picture. He had pink frothy tinged secretions consistent with pulmonary edema from the ET tube after intubation. And then you can see the x-ray there. The patient was started on a naloxone infusion and managed for ARDS with flash pulmonary edema with hypoxic respiratory failure. This is not an uncommon presentation. There are case reports in adult studies where you do see pulmonary edema in adult patient cases, but specifically to our pediatric population, we have seen a huge uptick, anecdotally speaking, with hopefully some numbers pending research-wise, but where kids are progressing to severe ARDS with flash pulmonary edema that are requiring significant support, as you'll see this patient has required. Over the next 24 to 48 hours, the patient's neurostatus improved. However, his respiratory status remained problematic. And despite maxing conventional ventilation strategies, he developed unrelenting hypoxia and hypercapnia. So the patient was then cannulated for VV ECMO at about the 48-hour mark. At that point in time, his oxygenation index was approaching 40 and a very rapid progression. Despite hopes that he would be able to be maintained with conventional ventilation, that was unsuccessful. While on ECMO, the patient actually returned to his neurologic baseline, and as with many pediatric patients now, was able to communicate and were able to do a fair amount of mobility and exercise, things like that, while on ECMO. He was a little bit limited because of circuit dysfunction with his cannula was just very positional, and so too much movement caused his circuit to dysfunction, but fortunately, his neurologic status was much improved, and we were able to continue to rehab his lungs. We saw gradual improvement in his clinical and radiographic exam. He was decanted from ECMO after 3 days, and then another 2 days after that was extubated. In the long run, he had no other additional organ systems that had any lasting injury. So this course that we saw I'll say he was one of the lucky ones. We had many who presented with very similar fashion, but unfortunately the downtime at the party or wherever they were found was prolonged, and unfortunately we've had multiple patients who did not survive. But again, we're seeing these in sort of a rash of presentations where we'll have a new shipment of drugs that come into town, into a rural town, and as those get distributed, we start to see a handful of kids get admitted because of the higher concentration in fentanyl than what they're used to getting in their previous pills, because there's no way to tell how much fentanyl is actually contained, or if it's oxy like they thought it was versus fentanyl, which they were not expecting. This is just really for your reference as far as things that we're looking for with fentanyl intoxication or poisoning. Vital sign changes, obviously these patients presented pretty classically with an opioid ingestion. Decreased heart rate can be present. Blood pressure can sometimes be decreased, but oftentimes the hemodynamics are stable. The respiratory rate is obviously one of the important signs and what we're directing our treatment at, so that's important. And then temperature can often be decreased just because these patients can be found down in an exposure type setting, and so you can see that change. Decreased bowel sounds, sedation or coma, seizures are possible, especially with co-ingestions. You can start to see other symptoms as well, but these are specific to opiates. And then the constricted pupils. Talking about the receptors that these medications are hitting, again, really just for your reference, but where these symptoms are coming from, this is why we're hitting the mu1 and 2 receptors, getting those sedation effects. Diagnostic evaluation, so obviously we have to rule out other potential causes, especially in the younger age groups where we don't have a clear history of ingestion. So often it's an accidental, they found this pill, or maybe they found this pill, or we have these meds in the house, so potentially they got into it. Whether or not the family actually knows and is upfront with that information or not, we still have to be suspicious of it. So you want to make sure that you've checked other causes for coma-type symptoms. Hypoglycemia is a big one. Getting a CK if there was concern for prolonged immobilization, because obviously that can cause renal issues and things down the line. Chest radiograph for concerns for aspiration, but then also things like the ARDS, which we saw for that second patient. And then looking for other co-ingestions, specifically Tylenol is a big one that we have. And then an electrocardiogram as well, especially with co-ingestions. So treatment, I won't go through this because we've talked in detail. We've talked a lot about this. Really, it's administering naloxone and then optimizing our respiratory status with oxygen supplementation, airway protection with intubation if needed, and then support from that point based off of what your vital signs and exams show you. We've talked about the dosing as well and shown you that. I think one of the things that it's important to highlight again, because sometimes we're just used to wanting to see complete improvement in a patient's status when we're directing our therapies, and that this is goal-directed therapy for respiratory status improvement, not necessarily return to neurologic normal. So in your redosing of naloxone, that's what you're looking for, is actual response from a respiratory standpoint. Eventually, there should be neurologic improvement as well. So why is fentanyl so dangerous? A lot of this information comes from the DEA.gov One Pill Can Kill website, which is very, very valuable information. I encourage all of you to explore this website and see what they have as far as education for families, patients, and communities, because it's becoming a growing issue across the country. But specifically, as you'll see with the data from Utah specifically, we're seeing a huge increase in issues related to fentanyl. But the fentanyl itself is approximately 100 times more potent than morphine and 50 times more potent than heroin. So it doesn't take a whole lot of the medication for it to be lethal. And so that's obviously makes it easy for these little kids to get into it and have issues very quickly. So you can see the bottom right picture is the one I was talking about earlier. how could a small child not see this collection and think that this is candy and something that they should enjoy? It's a little bit concerning there. The top right picture, I think, is very telling. That's a fake pill on the right and an authentic pill on the left. Pretty difficult to establish, especially when you feel like the fake one looks actually more pristine than the real one. So easily tricked to not pick up on when you're getting counterfeit drugs. That can be concerning. So drug cartels are making fentanyl. They're pressing it into these fake pills, and they're made to look like Oxy is a big one, but also OxyContin, Xanax, Adderall, and other pharmaceuticals. Excuse me. The street names, I won't read through all of those, but I think it's important for us to have an idea. And this website also lists street names, code names for many other illicit drugs as well. And it can be important to know, especially as you're working in communities, to have an idea of if you're hearing these things thrown around. And how it can be abused essentially in every way possible that you can think of to get medication inside somebody. So why do we care? Specifically to Utah, I think these graphs are maybe hopefully a little bit eye-opening for some. But this first one is looking at the percentage of all drug-involved deaths in Utah. The prescription opioids you can see with a pretty significant effort through 2010 to 2020, a nice decline in those deaths. But you also see in the 2018 to 2020 range, the fentanyl-related deaths has spiked rather dramatically. And I think that's an important trend to note. Doubled from 2019 to 2020, a 125% increase. And then the second graph is looking at fentanyl mortality and law enforcement seizure data. So you can see the increase of, I think it's 900% in fentanyl seizures in just the months of January to March of 2021. That's an increase of 900% compared to all of 2020. So that's a huge increase where we're seeing seizures, and then you can see the fentanyl overdose deaths related to that, increasing at an alarming rate as well. So more statistics specific to Utah. On average, 475 people a year in Utah die from unintentional drug poisoning deaths. Utah was ranked 28th in the U.S. for unintentional drug poisoning deaths, which outpaced deaths due to firearms, falls, and motor vehicle crashes. In pediatrics, we see a lot of these types of traumatic deaths and injuries, but we're starting to see these overdoses, unintentional or otherwise, catch up to those numbers. 323 people die from a prescription opioid drug overdose, 156 from heroin, 88 from synthetic opioid overdose. That's per year in Utah. And then hopefully it goes without saying, and one of the reasons we have DCSF involved is living in a household with substance abuse is an adverse childhood experience. Unfortunately, all too often, we see them in the pediatric setting when we're too far down that road, and they've often already come in contact with these drugs or medications multiple times. And so, unfortunately, we're kind of behind the eight ball in that respect, but it's definitely a problem moving forward with their development, socially speaking, and potentially affecting their ability to be in school, to get and maintain jobs, et cetera. How are kids getting it? So if you are familiar with social media, which I assume most of us are at this point, there's a lot of advertising going on right in front of your face for illicit drugs and their marketing. And these are some of the emoji codes that can be used in trying to sell these illegal substances. So recognizing these and helping families to recognize these to help monitor what their children are being exposed to and what they're seeing is important. Obviously, these things are changing a lot, but the One Pill website is very helpful because they do a lot of work to try and keep up to speed with these changes. Again, that's the website that you can use. And then why should we be concerned? Obviously, over time and really very rapidly, the landscape of drug movement is changing, and all parents and caregivers have to be directly involved in preventing the progression of this, especially within their own families and their own communities. There's a lot of resources as far as what things can we do as tips for caregivers and parents on these websites, ways and things we can use to talk to our kids, our patients, our families, our communities. Really, a lot of these, I'll just kind of throw them up here really quick for sake of time, but a lot of common sense stuff. But unfortunately, it's not happening very frequently, and so I think it's important to highlight still. Encouraging open communication, explaining why this is so dangerous, explaining that if we don't know where the pill came from, it can't be guaranteed as safe. And just because it looks real and legitimate doesn't mean that it is. And so making sure that kids are as educated about this as possible. And then things like creating an exit plan to help your child know what they can do, what options they have, what resources they have if they're found in one of these situations is important. As caregivers, as people working in the medical field, whether it's in a community center, in outpatient facilities, in hospital facilities, I work in a pediatric ICU, and I've had multiple codes within the last 2 years of people who were visiting patients in the hospital who overdosed in bathrooms or in the cafeteria. That's how prevalent it is and can be. So it's not that you won't come in contact with it. So I would just say to be prepared. If you do happen to come in contact with a situation where you're concerned about overdose, you have to be prepared and appropriate in that situation. We've had police officers who have come in with opioid intoxication because they came in contact while they were apprehending a suspect, or investigating a scene because they were unaware that a liquid that they came in contact with was in fact fentanyl or other illicit drugs. So it's important to pay attention. Obviously, we don't want to inhale anything or ingest anything, but even just touching our eyes, our nose, any mucous membranes can easily transmit, and so we just want to be careful with that. And like we talked about before, there's lots of different ways that these medications can enter the body, so just being cognizant of that when you come in contact with somebody and have that specific concern. Bathrooms are a nice, easy way to quickly have some privacy and try and accomplish these tasks with drugs. And so I would say that's most commonly where we see these things happening illicitly in the hospital. We had a mother who was waiting for their child in the operating room, and no one could find her after the patient was done with surgery, despite looking for over a half an hour, and she was unfortunately found down in the bathroom. She had been using drugs in that waiting room bathroom. So things are happening right around us, and so it's important to be aware. This last slide, again, is just for your benefit. If you're coming into contact with any of these types of situations, to be careful and avoid those contacts. And that is all I had. We'll give time for any questions. Yeah.
These pills, are they from Central America? Where are these coming from?
Yeah, so it looks like a lot of the ones, I think I might have put the specific cartel names without wanting to get into too much political stuff. We have in Arizona specifically been able to track them to different cartels within Mexico specifically. But the route in which they are spreading, the drug cartels are getting very smart at how they're distributing the medications. And so it's quickly, the routes are changing and distribution is changing. But yeah, Mexico and other Central American countries are the main source right now. Yeah.
Yeah, just a comment. A book that recently came out, The Least of Us by Sam Quinones. He actually details in really graphic ways how this whole, starting with the opioid overprescription by us,
Mm-hmm.
which softened up the U.S. culture, and then how the heroin started coming in, and then fentanyl that came out of China first, then to Mexico.
Yeah.
Actually, it's out of China, sold directly on the internet, and then into Mexico, and they took it, and how it's a wonderful book, and something that's, I think, really helpful in helping us to understand how this is coming about.
Yeah, very, very eye-opening.
Scary it really is.
Yeah, I agree. Yes.
Have you seen any cases of xylazine yet?
Sorry?
Have you seen any cases of the xylazine?
Oh, have we seen any cases of xylazine? Not specifically yet, but we're still tweaking some of our drug testing to know for sure. Unfortunately, a lot of the times, by the time they get to our center, a certain amount of time has elapsed that we don't always catch the offending agent. But yeah, I imagine it's to be seen soon. Yeah.
Is there any recommendations you change with pediatrics with using naloxone differently, or?
So really the biggest difference is it's weight-based dosing under 20 kilos. So the 2 milligram starting dose is standard for above 20 kilos, and you can, depending on severity, even double that to start. When they're under 20 kilos, we'll go by per kilo, 0.1 per kilo. So that way when you hit 20, it's 2 milligrams. So not hard to remember.
Do you tell them to do anything different with like the nasal sprays at home or anything?
No, repeat every 2 to 3 minutes as appropriate, but that's same as across the board. Yeah, I think it's nice that it's kept pretty standard in EC for anyone who happens to be able to administer it. Yeah.
My first thought on the one case we had in the very opening screen was copious respiratory secretions. I thought you were going to go down a cholinergic path.
Yeah.
Then he was taking multiple drugs.
Mm-hmm. Yeah, that's a great point. The copious secretions and a cholinergic response with the second case, the adolescent. And that was definitely a consideration initially. With co-ingestions, you can get a myriad of presenting symptoms, and you have to investigate each of those different avenues because who knows what they've gotten into. So yeah, that was definitely a consideration. And then with the intubation, the pink frothy secretions, the X-ray consistent with pulmonary edema kind of brought us a different direction over time. But yeah, definitely a concern. Excellent. Thank you.
Thank you.
Yeah. Appreciate it.